Hi, good morning, everyone. My topic today is remote anesthesia. I came across this term NORA while preparing for this presentation. NORA stands for Non-Operating Room Anesthesia. Anesthetists are increasingly being asked to provide anesthesia in locations outside of the OT. These locations include radiological suite, invasive cardiac lab, endoscopic unit, and psychiatric unit. Before I present to you what are problems in NORA, I would like to share with you this study. These studies show that mortality increased with NORA as opposed to conventional OT anesthesia. Substandard care is also more prominent in NORA, with many complications could have been prevented with better monitoring. NORA claims were mostly associated with sedation in extreme or age. This table illustrates a common complication with sedation in NORA, such as airway obstruction, aspirations, respiratory depressions, apnea, and etc. Our aim in NORA is to ensure patient safety and comfort, facilitate the performance of the intended procedure. Now let me introduce three-step approach to NORA focused on the patient, the procedure, and the location. Patients who are mentally disabled, confused, disorientated, uncooperative, anxious, and claustrophobic often require GA. The patient can also be elderly with multiple comorbid or morbid obese. Don't forget those with potential difficult airway and movement disorder. NORA is also often required for prolonged, complex, painful procedure or procedure limit access to patient airway. Certain procedures also require patient to be in uncomfortable position such as prone. Remote location with lack of skilled assistance, medication and resuscitation equipment put both the patient and the anesthetist at risk. In NORA, anesthetists are asked to work in unfamiliar surroundings. These remote locations are not designed for anesthesia with the following problems such as limited walking space, no center pipeline, limited power supply, poor ambient light, or most importantly, unlike in OT, we have limited access to the patient. ASAs have provided the following guidelines for NORA in order to improve the quality of patient care. These include reliable oxygen supply with backup suction equipment, adequate monitoring equipment, emergency card with defibrillator, drug and airway equipment such as ambu bag, sufficient electrical outlet, sufficient space for anesthesia personnel and equipment, adequate lighting, appropriate post-anesthetic management. NORA often require remote monitoring. Qualified anesthesia personnel must be present for the entire case. Same standard as in OT apply. Minimum with SpO2, NIBP, ECG, and temperature. If end-tidal CO2 monitoring is available, it can be very helpful. Ensure oxygen failure and disconnection alarm is working properly. Appropriate recovery facility and staff not lesser than the generality must be provided. The key to safe NORA is planning and preparation. Know the physical layout of the location and unfamiliar anesthetic equipment. Verify the ability of assistant. Anticipate problem before starting the case. Must have a contingency plan in the event of emergency and adverse outcome. ASA standards for NORA are similar to anesthesia in general OT. We need to perform complete anesthetic assessment, adequate fasting, obtain informed consent, formulate a plan, implement the plan and adjust as needed, monitor the patient. ASA level of sedation is important as sedation is frequently given in NORA. This is a simplified version. Usually we are targeting conscious sedation in which patient is still able to respond to verbal command or light touch, and the airway is maintained. We must follow this sedation guideline. Sedation must be given by qualified personnel, monitor, evaluate, rescue the patient if needed, documentation and supervised recovery. Remember, the depth of sedation is a continuum of progressive change in connection, respirations, and protective reflex. Use single drug, titrate the drug to the recognized sedation endpoint, allow initial dose to have full effect before additional dose. Painful procedure require administration of a specific anesthesia agent. Use LA for localized procedure. Multiple drug combination produce synergistic effect defer time to onset and peak effect, result in difficulty to titrate to effect. Milozam is a useful sedative. It produces anti-Greek amnesia and causes minimum hemodynamic effect if given in titrating dose, but it can cause loss of airway reflexes, respiratory depression, and apnea. Give initial dose 2 mg followed by a pause of 2 minutes to observe its effect before giving further 1 mg increment. Reduce the dose by half in elderly or compromised patients. Opioid anesthesia where required should be given before midazolam, as opioid increase midazolam potency. Propofol have a narrow margin between conscious sedation, deep sedation, and GA. Mean plasma concentration for propofol required for conscious sedation is 2 mg per ml, with the dose range between 1 to 3.5. Start with a target plasma concentration of 1.5, titrate in 0.2 increment to produce the desired level of sedation. Remember to reduce the dose in elderly or compromised patients. Picidex has an anxiolytic, sedative, and analgesic property, but it has a reputation to cause hypotension. Hypotensive effect can be avoided by omitting rapid infusion, such as reduce the loading dose. Picidex does not impair respiratory drive and cause apnea. Easy way to remember loading dose is 1.5 body weight in mL per hour for 10 minutes. Maintenance dose is 0.5 for 50 kilo is 5 mL per hour. 12 papers were included in this systematic review comparing Picidex and midazolam. Picidex is shown to have advantage over midazolam in terms of reliability, analgesia, patient and clinician satisfaction. Picidex and midazolam appear to have similar cardiorespiratory safety profile when both are carefully titrated. These are some of the results from the study. Bring along fumagenial when planning sedation using midazolam. It is a competitive antagonist for benzodiazepine at the recognition site of GABA A receptor. Initial dose of 0.2 mg, then repeat dose if no response after 1 minute. May repeat at 1 minute interval to the maximum dose of 1 mg. Usually see effect with 0.6 mg. Common procedures done in radiological suites which require anesthesia are CT scan, MRI, and interventional neuroradiology. The rooms are crowded with bulky equipment, and patients are often required to keep still for a long period of time. This remote location poses unique hazard with radiation exposure and contrast media reaction. Another problem is inaccessibility to the patient. Reaction to contrast media can be varies with itchiness, urticaria to anaphylaxis. Oral steroid can be given prior to procedure in patients who have history of allergy. Immediate access to resuscitative drug and equipment is crucial. CT scan is less complex with less energy time required, but it requires a patient to be immobile. It is often noisy, warm, and claustrophobic. CT scan has a higher level of radiation exposure. MRI has unique problems associated with strong magnetic field. MRI is contraindicated in patients with implantable electronic device such as thermal pulse maker or AICD. Patients must be screened for contraindication. Magnetic resonance compatible equipment must be used for monitoring and maintenance of anesthesia. Ear protection is mandatory for all patients undergoing MRI. Patients who are mentally disabled, confused, disoriented, and claustrophobic require GA. The patient airway always head first into the magnet is completely inaccessible. To make it worse, a reusable coil is placed around the airway. If it is a head scan, reduce the space for ETP and connection. Anesthesia is induced outside MRI room on the MRI safe trolley. Never bring matter into the MRI room. MRI compatible GA machine will be a great help. Otherwise, place the TCI pump in the control room connected to the patient via a long line. MI requires remote monitoring. Therefore, alarm must be visual. In an emergency, take the patient out from the MI room. Do not take emergency equipment to the patient. Common interventional neuroradiology procedures include cerebral aneurysm coiling, embolization of AVM, and microembolized removal in cerebral ischemia for acute ischemia stroke. GA is ideal for motionless patients and episodes of controlled apnea. GA is also preferred due to potential catastrophic bleeding. Follow this basic neuroanesthesia principle. Optimize CBF, CPP, control ICP, careful monitoring of systolic blood pressure, fluid status, and body temperature. Facilitate smooth and rapid emergence. Anesthesia for cerebral aneurysm coiling is a very common topic in the exam. Apply protection strategy, maintain hemodynamic stability, and normochemia between 35 to 40 mmHg. Avoid hypoxia to prevent secondary damage to the brain. Insert large bore IV balloon. Insert CBD in view of large endovascular catheter flush. GA can be maintained by inhalation anesthesia with intermittent neuromuscular blocking agent or TIVA with propofol and remifentanil. The anesthesia is often required to give heparin to prevent vessel occlusion. Need to have a contingency plan in the event of annular rupture and bleeding. Transfer the patient to OT for immediate craniotomy. Treatment include maintenance of CPP, lowering ICP, and reversal of anticoagulation. Many cardiology procedures such as pacemaker insertion, cardiac aspirations, or transesophageal echocardiography are commonly done under remote anesthesia using moderate sedation. Choice of sedation can be highly variable. Our aim is to minimize the effect of anesthetic on the cardiovascular system. Cardioversion is usually planned procedure for the anesthetic team. Patient conditions are usually optimized. Cardioversion requires deep sedation. Midazolam and propofol are frequently used. Put patient on a ventilator mask. May switch to ambu bag if airway and spontaneous ventilation compromised. Look for the loss of the eyelid reflexes and proceed. Patients requiring GI intervention are often elderly, have cardiorespiratory problems, and dehydrated. Upper and lower GI endoscopy are commonly performed using conscious sedation, usually midazolam and opioid. ERCP frequently requires systemic anesthesia. TCI, TIVA, propofol can be used effectively in technically more challenging or time-consuming GI endoscopy procedure. ECC used mainly to treat major depression. The parasympathetic discharge is often followed by a sympathetic discharge associated with hypertension and tachycardia. As a result, ECC can cause increased ICP, IOP. Contraindications are recent MI, recent stroke, and uncontrolled hypertension. Our aim is to provide anesthesia and rapid recovery, prevent injury, control hemodynamic stability, avoid interference with the initiation and duration of the desired seizure. Patients often had this procedure multiple times. Therefore, you can use the old record as template. Apply standard monitoring. Give glycopyrrolate 0.2 mg to prevent bradycardia and sedation. Pre-oxygenate with 100% oxygen. All current available induction agents are suitable except ketamine. Propofol is the most commonly used. Give succinylmetronidazole of 0.5 mg per kilo. Place the bite block. Goal is seizure between 30 to 60 seconds. Ventilate until spontaneous respiration returns. ECT can cause confusion, agitation, violent behavior, headache, muscle pain, nausea, and vomiting with emergent agitation can be the most difficult to treat. Small dose of midazolam may be useful, and the presence of a trained escort familiar to the patient can be reassuring. My take-home message for you: remember the three-step approach. And the important aspect in NORA, remember this mnemonic: MAID, monitor, assistant, drug, and equipment. Thank you.